So I was given the task of discussing practical advice regarding the use of GLP-1 receptor agonists during Ramadan. And I'm going to be talking predominantly about the injectable GLP-1 receptor agonist, and I'll touch also on the sole oral GLP-1 receptor agonist that is available in some markets. And certainly there would be some listeners this evening that have already had experience with the oral GLP-1. I was discussing GLP-1 receptor agonists as one of the relatively newer classes of anti-hypoglycemic agents. We've seen them evolve from the short-acting injectable agents to the long-acting weekly GLP-1 receptor agonists and the oral GLP-1 more recently. So GLP-1 receptor agonists work by activating the GLP-1 receptor at the level of the pancreas by increasing insulin secretion, and they also have an effect on glucagon. Patients with type 2 diabetes have high levels of glucagon, and reducing glucagon is beneficial with respect to helping control hyperglycemia. Now, GLP-1 receptor agonists are incretin mimickers. They exert their effect on glucose in a glucose-dependent manner. Therefore, there is a reduced risk of hypoglycemia. But that's not all. They also work by reducing appetite. They reduce appetite by increasing satiety. There are GLP-1 receptors centrally, which promote fullness, decrease hunger, net effect of reducing energy intake and promoting weight loss. They also have effect on the gastrointestinal tract, predominantly by reducing gastric emptying, which also helps promote satiety and also reduces postprandial glucose. Now, the main adverse effects are gastrointestinal, nausea, vomiting, and diarrhea. The good news is that most patients will only have these side effects in the first few weeks. There are some patients who persist and develop intractable GI side effects where the GLP-1 receptor agonist has to be stopped. But in the main, most patients will be fine after the first few weeks. And this is why it makes it really important when we start these treatments that we counsel our patients about what to expect and also about tips to mitigate the GIT side effects, such as stopping eating when they're full, maintaining good hydration, avoiding fatty foods, fried foods, and spicy foods in that first few weeks when they're getting adapted to the GLP-1 receptor agonist and every time the dose is escalated. So GLP-1 receptor agonists, the injectable formulations, can be split up into short-acting, so lixisenatide, and exenatide short-acting, which are given usually within an hour or within an hour before a meal. Exenatide short-acting is twice a day, start at 5 micrograms, titrate after a month if tolerated to 10 micrograms. Lixisenatide, 10 to 20 microgram once a day. Liraglutide kind of fits in between the short-acting and long-acting. It's a once-a-day subcutaneous injection, and importantly, it can be given at any time of the day, independent of meals. And this has ramifications for patients who are going to be taking liraglutide during Ramadan fasting. Now, the long-acting weekly GLP-1 receptor agonists I've listed here, exenatide modified release, and the latter two, dulaglutide and semaglutide, are the predominant weekly GLP-1 receptor agonists that are in use, especially in our Australian market, and I dare say in most other markets around the world. These weekly long-acting GLP-1 receptor agonists are more effective in controlling glucose, lowering HbA1c, and also in promoting weight loss, in particular high-dose semaglutide, and I'm sure a lot of you have had experience with that with your patients with diabetes. Now, there have been two main changes to the guidance in managing type 2 diabetes since 2018, and these have been updated annually as part of the American Diabetes and European guidelines. The first major change in 2018 was that for the first time, guidance on the use of anti-hypoglycemic agents were based on comorbidities. So those comorbidities are the presence of atherosclerotic cardiovascular disease or indicators of increased cardiovascular disease risk, as well as history of heart failure or chronic kidney disease. And that is because certain members of the GLP-1 receptor agonist class and also SGLT2 inhibitor class have been shown in clinical cardiovascular outcome trials to result in a reduction in cardiovascular events and also a reduction in progression of chronic kidney disease in the case of SGLT2 inhibitors. So that was a major change at the time. And what that has led to is an upgrade of GLP-1 receptor agonists to perhaps not commonly used second or third or even fourth line therapy to a very commonly used second line therapy after metformin. So these are the cardiovascular outcome trials I was referring to, which most of you will be familiar with, which showed superiority for the weekly GLP-1 receptor agonists in the case of semaglutide, albiglutide, and dulaglutide versus placebo, and the daily liraglutide in the LEADER trial. Now, the other major change was the advice regarding the use of injectable agent when you need the greater glucose lowering effect of an injectable agent. Now, prior to 2018, insulin was preferred, but based on the evidence, the weight of evidence up until then, which showed that the weekly GLP-1 receptor agonists in particular were at least as effective as basal insulin, in some cases, in some trials, more effective, at the same time resulting in a reduced risk of hypoglycemia and associated weight loss. And based on all that evidence, now the advice was that GLP-1 receptor agonists became the preferred choice to insulin when it came to choosing an agent to control glucose when you've exhausted tablet therapy. So that was the other major change at the time. So these changes have resulted in sets of recommendations that have been updated. This is a busy slide. I'm not going to go into too much detail, but essentially the American and European guidance is that we consider these agents, GLP-1 receptor agonists, SGLT2 inhibitors, early on if we're looking at using an agent in a patient with a history of cardiovascular disease, or if we want to promote weight loss, or when we want to avoid hypoglycemia as an add-on to metformin. These are our Australian guidelines, which have resulted in the upgrading, as mentioned, of GLP-1 receptor agonists to commonly used second-line therapy after metformin. And I guess here in our market, we are also fortunate to have reimbursement for our weekly GLP-1 receptor agonists in our diabetes patients in most scenarios. Now, what does the management of type 2 diabetes when fasting during Ramadan practical guidelines say regarding the GLP-1 receptor agonist class in patients who desire to fast during Ramadan? So if we look at the chapter and the guidance, essentially the guidance is that patients who take a short-acting GLP-1 receptor agonist, such as lixisenatide or exenatide or liraglutide, do not need their dose adjusted during Ramadan fasting. So that is based on experience and also a number of clinical trials, which I'm going to discuss if I can get this slide to move forward. So the LIRA Ramadan, okay, so the Treat for Ramadan trial examined the safety and efficacy of liraglutide compared to sulfonylurea treatment as an add-on to metformin. And this study showed there was a reduced frequency of hypoglycemic events in patients who took liraglutide versus sulfonylurea as an add-on to metformin. The primary outcome was the combination endpoint of HbA1c less than 7%, no weight gain, and no severe hypoglycemia. There was a non-significant advantage of liraglutide over sulfonylurea. LIRA Ramadan study was a similar trial which also looked at liraglutide versus sulfonylurea as that onto metformin. And in this trial, patients in the liraglutide arm had better weight control, fewer confirmed hypoglycemia, and the primary outcome was met and was statistically significant. Now, so liraglutide is deemed to be a safe add-on treatment to metformin in fasting individuals during Ramadan. It has a low risk of hypoglycemia. It helped lower HbA1c and was effective in reducing weight during and post-Ramadan. There is one study looking at exenatide, which I won't go into any detail. And I also won't go into too much detail with regards to the lixisenatide LixiRam study, which is lixisenatide plus basal insulin versus sulfonylurea plus basal insulin. This was the first wave of this trial. I think tomorrow Mohammed Hassaneh is going to discuss the second wave. And essentially what this trial showed was that there was a decreased frequency of hypoglycemia, both documented symptomatic and all hypoglycemia in patients who took lixisenatide plus insulin versus sulfonylurea plus insulin. HbA1c reduction was similar in both arms. So what about the weekly GLP-1 receptor agonists? So what do we do with those agents during Ramadan fasting? Well, first of all, there's little evidence or no evidence with respect to looking at weekly GLP-1 receptor agonists in Ramadan. So we're lacking in that area, particularly in the two weekly agents that have the cardiovascular outcome benefit, dulaglutide and semaglutide. But essentially, their doses are given independent of meals So no dose adjustment is required. However, some patients may wish to avoid injecting during sunrise to sunset fasting, so they can easily change the time of their injection to in the evening after their iftar meal, and it's once a week. So there's an advantage in that regard. What about the short-acting GLP-1 receptor agonists? I've mentioned to you that there doesn't need to be any dose change, but there will be some patients who would wish to avoid injecting their evening dose prior to their iftar meal. Remember, I said they need to be injected within an hour of that meal. So in those situations, if the patient's taking twice daily exenatide or once daily lixizanatide, they can move the timing of that injection to the evening with a snack, so they're not necessarily having to wait half an hour or an hour before their iftar meal. Now, with once daily liraglutide, this is something that doesn't need to be given around a meal and can be given after the iftar meal. There's no specific gap required between the dose and the meal, and the dose does not need to change either. So what are the concerns about GLP-1 receptor agonists during Ramadan fasting? So as is the case with SGLT2 inhibitors, there's always the concern that prolonged fasting can cause exacerbation of dehydration, especially if the patient is having nausea and or vomiting or gastrointestinal side effects. So far, the studies of GLP-1 receptor agonists in Ramadan have shown a low risk of dehydration or infection, and this is an important point. It is really preferable to avoid dose titrating the GLP-1 receptor agonists close to Ramadan. Ideally, the patient should be established on a stable dose about a month before Ramadan to avoid the gastrointestinal side effects that could compromise someone's ability to fast during the Ramadan fasting month, or also perhaps cause them to develop significant volume depletion if they're suffering an increase in GIT side effects, which we sometimes see as we escalate the dose of the GLP-1 receptor agonist. So if the patient is not on the maximal dose, it is advisable to defer dose escalation until after Ramadan. And it's also important, a number of patients that take the weekly GLP-1 receptor agonists often notice that in the first couple of days after their dose, their weekly dose, they still have some nausea. And so therefore, it is important to encourage them to maintain good and increased hydration during the non-fasting hours, especially in those first couple of days after their weekly dose. Now, if the patient is unable to tolerate their GLP-1, you can either reduce the dose if there is a lower dose available with that GLP-1. For example, semaglutide, you might cut the dose back from 1 to 0.5 milligrams weekly if the patient is struggling during the fasting month, or you might have to stop the GLP-1 and use an alternative agent during the fasting month. Now, what about COVID-19? Now, patients with severe COVID-19 who have reduced appetite and gastrointestinal symptoms, I believe it is advisable to suspend GLP-1 receptor agonist therapy until the patient improves. If they have mild symptoms of COVID-19, it's probably safe to continue with fasting for Ramadan, but importance in encouraging to maintain good hydration and regular self-monitoring. Now, what are the advantages of taking a GLP-1 receptor agonist during Ramadan? Well, the advantages are that increased satiety can help reduce the overeating and binging during that feasting period once the fast is broken. So therefore, you might be able to help avoid postprandial hyperglycemia and overnight hyperglycemia, which is often hidden and missed by the patient. And also it will help reduce the amount of weight a patient potentially could gain during the fasting month of Ramadan because of the feasting that occurs. Now, I've already touched on the flexibility in timing, the dose of the weekly versions and the daily liraglutide can be given independent of meals. So it's a great option for the patient who wants a very simple regimen that they don't have to worry about altering because of the change in their timing of meals during Ramadan. Regular monitoring won't be required if the patient takes their GLP-1 receptor agonist with metformin plus or minus an SGLT2 inhibitor. And it's a desirable option for fasting patients who want to lose weight. And as already mentioned, patients with comorbid atherosclerotic cardiovascular disease or chronic kidney disease or increased CVD risk. Most of our patients come from high-risk ethnic groups where there is an increased risk of cardiovascular disease. So it is a very attractive option for patients to treat their glucose, not only to reduce their risk of CVD, but also to help them through that fasting month because of the advantages we just discussed. So we come to the oral GLP-1 receptor agonist, semaglutide. So I've listed the countries where it's approved around the world. Now, we don't have this agent here in Australia, but some of you from the UAE, India, Saudi Arabia, Singapore, Kuwait may already have experience with the oral GLP-1 receptor agonist semaglutide known as Rybelsus. So This has very particular dosing instructions. This particular agent has to be taken in the morning, fasting, with a small amount of water, and then you must wait 30 minutes before eating, drinking, or taking any other oral medication. If you don't, you're going to decrease the absorption of semaglutide. So it's very particular in terms of its dosing instructions. And on further review, fasting means a minimum of 6 hours of fasting. So whilst it might be attractive for some patients to take it at suhoor as opposed to iftar, so they don't have to wait that half an hour, which is very specific, that'll also depend on whether the patient has had that 6 hours of fasting before they wake up at suhoor. So in some parts of the world, this may not be practical. There is a dose titration from 3 to 7 to 14 milligrams, which is usually monthly, and ideally that should be avoided as per the weekly and the short-acting injectable GLP-1 receptor agonists. So as mentioned, practical concerns about oral semaglutide. Can it be dosed as suhoor? Well, probably, but the patient must have had fasted for 6 hours beforehand. Can it be dosed at iftar? Well, it may be problematic for some patients to wait that half an hour before eating. Otherwise, they will affect the absorption of Rybelsus during that time. So coming to the end, to summarize, GLP-1 receptor agonists during Ramadan fasting in type 2 diabetes are a very attractive option for a number of reasons. They promote weight loss. They are associated with a reduced risk of hypoglycemia. They don't require dose modifications, as I've already discussed. Certain members of the class have proven cardiovascular benefits, so they are a very attractive option for our patients with an increased risk of cardiovascular disease, which is a lot of our patients. So I certainly have enjoyed a lot of success in using GLP-1 receptor agonists in many of my patients with type 2 diabetes right across the spectrum, and it's made their lives a lot better in terms of glycemic control, weight loss, and it's also been an easier drug to manage during Ramadan. In terms of data, we don't have a lot with respect to the long-acting, weekly, and oral GLP-1 receptor agonists at this stage, but they may prove to be unnecessary or in terms of long-acting weekly, but the oral GLP-1 is an interesting one, and I'd be curious to hear any feedback from any of the other panel members that have had experience with the oral GLP-1s to date. So thank you for your attention, and I'll hand it back to the chair.